Welcome to Lesson 6.3, The Quest for Universal Health Coverage. So in the last two lessons, we've learned about what a health system is and that the goal of every health system in principle should be universal health coverage. And so this means that every person in a country should have access to a package of healthcare services that is paired with an insurance program that protects them from suffering financial hardship as a result of the healthcare costs. And an increasing number of countries, including low-income countries, are making progress towards universal health coverage. So I want to speak about this in this lesson. So WHO suggests that the aim of universal health coverage reflect these concerns. That one, people should have access to services regardless of their ability to pay for them. Number two, services must be of appropriate quality and that you're not providing poor health care to poor people. And third, the financial arrangements for services must protect people from suffering financial hardship. And so as countries seek to develop universal health coverage or universal health care, these are some of the questions that they probably face. Who should be covered? What services should be covered? And what share of the costs should the insurance scheme pay? That's very similar to Canada. There's certain things that our OHIP pays for and there's certain things that don't. And so when establishing universal health coverage programs, countries also need to assess the ways that they're going to pay their healthcare providers. This chart here from the textbook provides a framework of how to progress towards universal health coverage. So how do those low middle income countries progress towards highly developed or high income countries? And so it's suggesting looking at policies and programs and slowly progressing across the top here from just starting off by piloting new programs, developing new systems to where you have a mature program. And then the status of health coverage can start off very small with a low population coverage at the early stages, and then starting to look at building in more access to services with financial protection. And then looking at the next stage where, yes, you do have universal population coverage, but looking at improving financial protection and quality of services. And then at the fourth level is looking at universal health coverage, which is sustained. You've got comprehensive access to health services, and you've got an effective financial protection. So just giving some type of progressional framework of how low-income countries can move to where high-income countries are. In the previous lecture, I highlighted some of the key health sector concerns. In this lecture, we're going to look at those concerns and try and come up with some solutions of how to address these key health sector concerns. So the first concern was adapting to demographic and epidemiologic change. And so we discussed in previous lectures that as a country develops economically, they actually have a double burden of communicable and non-communicable diseases. And so perhaps the single most important step that low middle income countries can take today is to reduce that burden related to cardiovascular disease, and they may focus on tobacco smoking because we know tobacco is the #1 risk factor for cardiovascular disease. And so there's really good evidence that even in low-income settings, measures to make it harder and more expensive to buy cigarettes can reduce tobacco smoking. Another thing is that there's a high incidence of road traffic accidents in low middle income countries. And so maybe those countries can begin to look at road traffic accidents by looking at better engineering of roads, safer cars, and maybe more traffic reinforcements. And then as low middle income countries build their health systems, they can start to look at strengthening the health system, looking at those building blocks that WHO has suggested. Another model of care could be the increasing in having patients come back and have more frequent contact with primary care providers. And so it's just giving that ability to, yes, if you identify someone with hypertension or diabetes, it is that you have that more frequent contact to ensure that they are continuing to improve their hypertension status and their blood glucose levels are improving. So the second issue is stewardship. And we discussed stewardship in previous lecture that it's the governance. And so it will be very difficult for low income countries to make any improvement in their health system without good governance. And so if it's weak and corruptive, it's not going to really be beneficial to their health system. But there are some things that can be thought about. First one is the government could launch national anti-corruption programs. They could look at procurement systems. So procurement is securing those services that are required for the health system. So securing maybe an essential drug list, maybe securing an essential diagnostic list that they're going to be performing chest x-rays on everyone that develops shortness of breath. They need to increase their auditing of the health system, maybe contracting out services as appropriate and as a cost-effective way. Carry out customer satisfaction surveys. How are people doing? What's working well? What's not? What are people still sick with? And then another way is to engage the community in providing citizen report cards where the citizens are actually reporting their health status to the government instead of the government going out and finding that information. I would say one of the biggest issues with universal health coverage is human resources. So the lack of human resources is related to significantly a lack of staff, a maldistribution of staff, meaning there's not enough physicians for the amount of patients, the same with nurses, maybe inadequate training and quality of the human resources. And this is all coupled with the poor environment in which many of them have to carry out their work. So a lot of what's happening is brain drain. And so some would step back and say that we need to take a more shared global responsibility for these resources. But many low-income countries need to think about strategies to keep their workforce. So focusing on coverage, motivation to keep people in these countries, and improving the competence. Another way is to look at task shifting, where you're training lower level personnel to carry out functions usually reserved for higher level staff. And so this is something that I'm looking at in my research work in Ghana, is to develop the nursing workforce to provide primary health care with respect to chronic diseases. And then lastly is a number of countries also use financial incentives to encourage better performance of healthcare personnel. So those might include better salaries, additional payments for serving in hard to reach areas. So we've seen that here in Canada. Bonus payments for meeting certain health services or health outcome objectives. So keeping blood pressures below a certain rate, providing housing for people, special allowances for training. And so the government really does need to invest in their human resources. Now, absolutely, you do need the money to fund this. And so the scope for very low income countries to raise these additional funds is very limited. So what can they do? Well, they could shift resources from other areas of the economy because of the known high return on investment in health, and that if you have a healthy workforce, then your economy is going to be much better as well. Other countries are going to want to invest in your country because of your economic productivity, because the individuals in your country are healthy. Maybe shifting the expenditure within the health sector to a selected group of low-cost, highly effective investments. Like we talked about, decreasing the amount of smoking that happens in countries through tobacco control. Other things is looking at how to be efficient. 20 to 40% of expenditures on health in low-income countries are wasted by spending that is not effective or efficient. And so the WHO has provided resources and policies, programs on how to implement low-cost health services that are highly efficient. Financial protection for citizens and universal coverage is paramount. How do you do this? If countries can, they can raise additional revenue, similar to what I talked about on the previous slide, by financing health services, improving the efficiency of the health sector expenditure, again, going back to financial health planning. It's really important to reduce the dependence on out-of-pocket expenditures, enhancing equity, And maybe starting off by moving towards an aim to provide just some basic primary care packages with universal health coverage. And so, again, looking at just a very basic health promotion package that will prove to be beneficial and increase the health status of the country. And so this is one way of looking at essential universal health coverage and highest priority packages. So starting off with, just a high priority packages that focuses in on maybe maternal and child health, focuses in on just what are the biggest non-communicable diseases and how do we try and decrease those number of DALYs and deaths from non-communicable diseases, maybe focusing in on tobacco smoking and hypertension. And then going to an expanded priority package would be the next step, adding in a few other ideas. And then full universal health coverage would be your final area or final goal of where you want to be. Improving access to and equity of services is really part of the political will of the country and health system planning. So there's a lot of evidence that coverage of health services is inequitable in many countries, and we see that here in our country as well. And it often leaves those individuals living in difficult access areas, those with less income, less education, and less empowerment, have poor access to health. And so systems or health systems in countries need to use data from national surveys to identify those gaps in health status, and they need to specifically target health resources to the places most in need and the poor. Hence, again, the work I'm doing in northern Ghana, where these poor, vulnerable populations have no access to health services. And here we are bringing a hospital to these services with the help of the Ghanaian government. So we know that low quality health services waste money and are really dangerous to people's health. And so, although most of us believe that the quality is related to a reflection of the adequate financial resources that are available to these countries, there is a lot of research that suggests that you still can have good quality care even in the absence of these additional resources. So what can be done? So countries can carry out assessments of their quality gaps. They can provide better oversight, supervision, and continuing training to improve the quality of the care that's provided, using clear guidelines, protocols, algorithms when they're contracting out services that link the payment to performance, and that if you're contracting out services, health services, you want to make sure that they're good quality health services and you're seeing the good quality health outcomes. And maybe focusing in on staff being proficient at selected tasks. So making sure that maybe you have a core group of people that are proficient at providing some type of health services, and it's going to be a good quality health service. So looking at those kind of areas when you're thinking about providing that good quality care. So I want to end off this lecture by talking about primary health care, because there is no way that we're going to achieve universal health coverage without primary health care. So I want to give you a little bit of a history where this came from. So in the late 1970s, it was estimated that about 200 million people around the world had no access to adequate health care. There was vast inequalities between rich and poor countries, and also within rich and poor populations within countries. And the biomedical model was failing. And it was failing because it didn't take into consideration the social determinants of health. And so, as I've said previously, there was an international conference on primary health care in Alma Ata. And it was the premise that came out of this primary healthcare conference, it was that the world was going to achieve health for all by the year 2000. And so there was a declaration of Alma Ata. So the declaration is the promotion and protection of the health of the people is essential to a sustained economic and social development and contributes to a better quality of life and to world peace. The highest attainment of health possible is most important for the realization of this social goal, and it looks at all the social and economic sectors to provide health. So it's looking broadly beyond the biomedical model, and it's looking at that if we can ensure health for countries, it's going to build their social and economic development, and eventually all countries will be able to attain good health and be economically productive. There was a declaration of Alma Ata, and it focused on these guiding principles. So there was a set of guiding values for health development. There was a set of principles for the organization of health services, that it was efficient, fair, equitable. It has started off by addressing the priority health needs. It broadened the medical model to include the social determinants of health, and there was involvement of all sectors. So remember, we talked about the health in all model, or the whole government holistic model. And so its main message is that inadequate and unequal health services was unacceptable, and that we needed to economically, socially, and politically look at this. The other part of the Declaration of Alma Ata was that there was local ownership, that communities themselves could identify what their burdens were, what their disease burdens were, and solutions were created by the communities. So they owned them and they sustained them. And it was very broad. There was a continuity of care almost, or a continuum of care, where it went from, let's look at health promotion and disease prevention, but let's look at treatment and cure. And let's look at what's happening outside and outside of individuals, and looking at what are the social determinants of health. So this approach was almost immediately misunderstood by the medical community. They said it was a radical attack on the medical establishment. It was too broad and idealistic, with an unrealistic timetable, that you could never achieve health for all by 2000. They said there was lack of research for how comprehensive this approach was. They called it cheap care for cheap people. And then there was actually some unforeseen world events that happened. So there was an oil crisis. There was a global recession. There was the introduction of development banks, the World Bank. And so what happened was the development of these banks shifted these national budgets away from social services, including health, into other resources. And so what happened is that we went back to these very vertical approaches, these selective approaches, where they only looked at specific, focused, targeted treatment of diseases, of selective diseases with specific interventions, like HIV, like TB, and things like that. So we went back to this biomedical model again, with this real focus on these high mortality emergencies. And so again, the emergence of HIV/AIDS and the resurgence of tuberculosis that went along with that. There was an increase in malaria cases. And so the focus was, again, going back to these high mortality treatment based programs, but not looking at any of this broad-based programming and looking broader. And so went back to this siloing of everyone was working individually. Someone was working on HIV/AIDS, someone was working on TB, someone was working on malaria. But again, very much focused on the need of targeting biomedical treatments and not looking widespread to look at what else was happening, that HIV was rising incredibly, TB was rising incredibly. And so back to these silo approaches. And so Margaret Chan at the time, who was the director of WHO in 2008, said, you know what? We need to get back here. We've got the development of at that time, the Millennium Development Goals. We were looking at developing the Sustainable Development Goals. We were full-blown in the midst of an AIDS epidemic, where we actually did figure out that we needed to look at prevention and need to look a lot broader than just treating people with antiretroviral therapy and treatment, that we actually had to look a lot broader. And as I said, remember, AIDS epidemic was the birth of global health. And then we had this rise in chronic diseases and mental health, that were plunging people in below the poverty line, and there needed to be some type of step back and look at what was happening, and we needed to look at all the sectors again of how we could come forward with a multi-sector approach. And so this whole idea about returning to Alma Ata, which was primary health care. And so, again, the focus was looking at this horizontal approach, which was primary healthcare, back to a community focus, local ownership, looking at prevention and cure, looking at social determinants of health, and thinking about, all of a sudden primary healthcare. And if we thought about the Declaration of Alma Ata from 1978, it's actually offering global health a lifeline. It could strengthen health systems. You could implement cost-effective interventions in low-resource settings. It could tackle the growing burden of chronic diseases, and all by looking at communities and having communities identify their burdens and come up with solutions. And so what Alma Ata, and back to primary healthcare, is looking at is that we need to be diagonal. We need to, yes, look at the biomedical model here, which is the vertical approach. We need to look at this horizontal model, which looks at this comprehensive social determinants of health model. And so we need to take these both and not be competitive, but be complementary. And this is where nurses come into play, because we can see global health through the eyes of both a vertical and a horizontal approach. We can be the diagonalists. And so delivering primary health care is not hard. And so again, it goes back to focusing the services on the main burdens of disease for each country, strengthening the health system in each country to deliver their services effectively and efficiently, surrounded by what the community and what the country identifies as their main burdens, and then offering these activities through primary health care. So you would have the ability for individuals in small communities to have a primary care level where they could go and access everything that they need at a primary health care level. And then if needed, they could go to a district hospital if they needed more advanced secondary care. And so this was looking at how primary care could be implemented. And we'll talk more about this in our synchronous lecture. So the main messages are that the goal of every health system, in principle, should be universal health coverage. Lower income countries, you could start by covering as much of their population as possible with a package of essential services, looking at maternity-related interventions, childhood disease-related interventions, along with immunizations, malaria, TB, HIV, looking at a communicable disease perspective, and then tobacco, alcohol control, and maybe hypertension for a non-communicable disease control. And then over time, you could implement an expanded package of services, all the while taking into consideration that this all could be delivered through a primary healthcare approach.